Hello, Kidney Warriors! James here from Dadvice TV, your online kidney health coach, and this is Dadvice TV Live. For all of you who are joining us for the first time, welcome. Great to have you here. Make sure you subscribe to Dadvice TV over on YouTube. That way, every time there's new content, you'll be one of the first to know about it. And you get to catch these live shows where you can post questions, write comments that I see and my co-host gets to see. Now, for those of you that are new, let me introduce myself. My name's James. I have kidney disease, diagnosed stage 5, but I have focused on getting my blood pressure under control, eating better, and exercising. And as I have focused on being healthy, my labs have also improved to where I currently have no symptoms. I feel great and I have tons of energy. Now tonight we are going to be talking about blood sugar, which is a very, very important topic when it comes to talking about kidney disease, preventing kidney disease, and helping you, not kind of get things all messed up by, getting too many sweets and stuff. But to talk about that, we've got a great expert. You guys know who's here. You guys love him. Please welcome back again. It feels like it's been forever. It's been almost a month. Dr. Rosansky. Hey, Doc.
Hey, James. Good evening. Good to see you. Looks like we got a pretty nice picture tonight. I got a faster internet speed here, and hopefully the sound and the video will be better than sometimes it looks like it's kind of cutting up, but we're good tonight.
Awesome. Now tell the new people a little bit about yourself and your background.
So I am a kidney specialist who started the kidney program in Columbia, South Carolina at the VA and University of South Carolina, and I've taken care of kidney patients for over 40 years. I have retired from active clinical practice, but I continue to do research and continue to publish. And I published a book for you folks called Learn the Facts About Kidney Disease, because I know there's a lot of confusion, a lot of fear, a lot of misunderstanding about kidney disease. And I hope this book will help alleviate some of those fears and give you a hopefully easy to read explanation of the kinds of things you need to be concerned about regarding your kidneys. And I've published over 100 peer-reviewed publications. I've taken care of many thousands of patients, and I love doing these shows with James because I think I get to help some of you with some of your questions. I try to prepare my talks. These talks are real medicine. This is none of the woo-woo that I talk about. I give you the most up-to-date stuff for you to share with other folks that may have an interest. And hopefully we'll answer some of your questions at the end of the show like we always do.
Yeah, great. Awesome to have you here, Doc. And for those of you that are new, if you have a question, add it to the comments, and I tag them on my end, and I try to give Dr. Rowe a few of them during his conversation. But at the end, Dr. Rowe is great at setting aside some time to go through questions from you in the audience. Now, today's topic is an important one, but not one that really we get too much excitement about: blood sugar.
We need to, and I'm going to tell you why. First of all, this is for diabetics and non-diabetics. Your blood sugar and how your blood sugar varies is important for all of you. And we're going to tell you why in a minute. First of all, I'm sure you all know diabetes is very, very common. It's the commonest cause of kidney disease in the world, diabetes, the number one cause of kidney disease. And it's been estimated that up to 1 out of 3 diabetics may get kidney disease. So diabetes, the sugar, people call it, I got the sugar.
Yep.
Got the sugar is important. And what I'm going to try to do for you folks tonight is clarify what is important with the sugar, with sugar levels, which there's tremendous amount of confusion. Just like this confusion about what your EGFR is, what matters and what doesn't. So many people worry about CKD3A, which is EGFR 30 to 60. 3A would be 45 to 60, and not to worry. Very, very rare people get troubles when they have that level of VEGFR. So, unfortunately, when people get diagnosed with diabetes, they've already got damage. What is diabetes damage? What does it relate to? It probably relates to sugar, and how exactly that happens, nobody knows. But people with diabetes, people who have high sugar levels, will wind up getting, some will get eye disease called diabetic retinopathy, commonest cause of blindness, and diabetic kidney disease. Those two types of blood vessel disease from diabetes are called micro is little, microvascular. And the other type, and this is really important because this is the biggie, the other type of disease related to diabetes is the same thing we've been hammering about, atherosclerotic cardiovascular disease. Any of you who have CKD, to me, the number one thing for you to be concerned about is your higher risk of atherosclerotic cardiovascular disease. And James knows exactly what that is, right, James?
Yeah, and you know what? One day I'm gonna, before a show, I'm gonna practice how to say it because I can never say it.
Well, it includes heart attacks, strokes, the biggies, the baddies, and it also includes trouble with blood supply to your legs. We're going to get into it in a minute. Um, so what about controlling sugar and decreasing these problems with the blood vessels? Most people say, "Oh, I got to get my sugar under control. My A1C is A, B, C, D. It's this, this, and this." Just like people obsess with their EGFR, right?
Mm-hmm.
The new diabetes approach is no more glucocentric. In other words, not to be obsessed with your sugar levels or your A1C. And let me tell you why we've come to this point. First of all, if you control your sugar real well, will it matter? And I think this is important. I'm going to give you the research in a nutshell that looked at controlling blood sugars and whether it affected the little blood vessels, the eye and kidneys, or the big blood vessels, your heart, your brain, etc. First trial came out of the UK, and it was a 10-year study, and these were new diagnosed. So I will tell you this, if you are a new diagnosed diabetic, you are a young diabetic, I think tighter control, getting your A1C in a lower range matters, okay? Much less so in older folks, and you're going to hear why in a minute.
And
So
can
this
you,
study,
when
yeah.
you say older folks, what is older folks?
Oh, James,
Because I'm young at heart, though I now
yeah.
qualify for AARP, and I may fall in that older folks category for some
Yeah.
people.
Well, I think I told you this at another show, but I just turned 75. and I did a big paper on which you can find online, open source. Look at my name, about managing diabetes in older adults. I was going to call it elderly, and my geriatrician colleagues on the paper say, "No, we don't use that word," and I know why.
Exactly.
Look, I'm 75 now. Don't call me elderly. Okay, older, generally over 60. Let's just say that. Okay,
Very good.
there's no magic number. So what did that study found? Well, that study found, again, these were new onset, tight sugar control. Maybe you got less of the eye problem, the diabetes in the eye, okay? But not any good evidence of the big blood vessels, the heart, the brain, okay? Didn't really show it. Another study came out from the VA. These were older, 60-year average age, 60 years. And they studied these guys for 11 years. They looked at people that were controlled well and people that weren't controlled well by their A1C. Unfortunately, no difference in how many heart attacks or strokes they had. So didn't show any real benefit of the big stuff. People with diabetes are 2 to 4 times more likely to die of the big stuff, big vessel disease, heart attacks, strokes, okay? heart failure. Didn't show any benefit. Another study came out and they studied people for 5 years. And in this study, they were looking for like 6.5. Those of you who are diabetic know what I'm talking about. A1C 6.5 versus 7.3. Okay. And maybe, again, microvascular. This study over 5 years, maybe a little bit of benefit to the kidneys. So the kidneys and the eyes are the microvascular. Big blood vessel disease, no benefit. Okay.
Mm-hmm.
Which the atherosclerotic cardiovascular disease. The other thing they found in that study is a lot of hypoglycemia, low blood sugar. Dangerous, dangerous, dangerous. Gets worse. The next study, they said, okay, maybe we need to get tighter A1C to get a benefit. So they shot for a 6.
Yep.
Okay. And a lot of people are going on treatment in that 6 range, which I don't think they should be on. Okay. I don't think we should even be entertaining diabetes below 6.5 A1C. But anyway, here's what they did. They studied them for 3.5 years, really tight, try to get them to 6 or less. Well, guess what? They died more in the tighter blood sugar control than in the looser blood sugar control. And they had more low blood sugar, dangerously low blood sugar. So that's the reason when they go, hey, we don't want to get aggressive. And these were people that were at risk. These were people that were not young, were not nuanced, they were already at risk for getting a cardiovascular event. Okay. So tight sugar is not necessarily beneficial. Here's a case where it was a type 1, a young type 1. And in that, these were 13 to 40-year-old patients. In that case, tight sugar, new onset, strict sugar control, definitely. You're type 1, try to get as strict tight sugar control, insulin pumps. It will decrease the micro and macrovascular stuff, the stuff in your eyes, micro, and your kidneys, as well as decrease the big blood vessel problems. So for most of you, you're type 2. 90% of you are type 2. Most of you are older. And most of you are not going to benefit by that tight control of your blood sugar. And it could be very dangerous. All right. And so we're going to get into the rough guidelines to how to tailor what your A1C should be depending upon how old you are and what other kind of problems you are. But just in general, if you want to just have a general rule of thumb, if you're new onset and you haven't had a lot of damage to your kidneys or your eyes or your heart or your brain, that's when it may help. Here's a really fascinating thing. I'm giving you stuff right hot off the press, James.
Mm-hmm.
This is fascinating. This is what they call an observational study. So in other words, they look at people's blood sugars and they look at whether they had in their medical records evidence of eye, kidney, heart problems, right? And they found out that half of the people, when they were diagnosed with diabetes, already had damage to their eyes, their kidneys, or their heart. Okay. And that gets into a massive basket of patients. A lot of you out there may have been called this pre-diabetes. In other words, maybe James is one.
Yeah,
Like most of you folks,
when I was diagnosed with kidney failure, they told me I was pre-diabetic, and I cut sugar immediately, and my doctor, they wanted me below 6, and I got there on my A1C.
Okay, so again, I don't want you people to get excited about this and say, I need to get on medicine and stuff, because there's no proof. But just to show you how complicated it is, what they found in the 3 years before people were diagnosed, if they had normal sugars in those 3 years, they had less likely to have blood vessel damage. If they were pre-diabetic in those 3 years, they're more likely to have it. So, there's no easy answer. I will tell you this, James, I'll tell all the audience. we talk about this over and over and over again. We talk about your lifestyle.
Mhm.
We talk about your exercise. We talk about your choice of diet. Unquestionably, for yourselves, for your family, for your kids especially, if you can get rid of the fast foods, you can get rid of the sugary drinks, you can get rid of the sugary cakes and all that stuff, which we'll get into briefly in a minute, you are going to benefit yourself and benefit your family. Because there's some relationship, there's some correlation between having bad sugars and getting these things. Now, we haven't been able to show that treating diabetes is definitely going to slow all that down, but it certainly is worth taking on the lifestyle changes for yourself and for your kids. So, so the new trend is no longer glucose centric, no longer obsessing about A1C, because
Mm.
people realize we're giving out all these drugs. We're giving out insulin. Insulin doesn't decrease your risk of getting a heart attack or a stroke. I mean, is that sad? All these people taking shots of insulin, taking all these diabetic drugs. Why are they taking them? I mean, yeah, you don't want to get sugars too high. That could be dangerous. But rarely is that does that happen. Most of these people are taking these pills and the insulin with the idea that I'm going to live longer. But that has not been the case until
Ah.
very recently. And you had another doctor on a couple of weeks back that talked about some of these wonder drugs for diabetics, which
Yeah, Dr. Gibney.
we're going to touch on again tonight. And I'll tell you, folks, these drugs are so interesting, and they are coming at us so fast that we are going to talk about these new drugs in many future episodes. I'm just going to briefly touch on them tonight. So, what's the new emphasis? We're not going wild about, certainly not under 6. And, we don't want to overtreat diabetics because low sugar can kill you.
Mm-hmm.
So basically, if you're a relatively young person, new patient, newly diagnosed, young, go for it. Go for less than 6.5 by all means.
And that's on the A1C, not the blood glucose, because
That's
it's a different.
A1C 6.5. If you're a new diabetic, you're a young diabetic, certainly all type 1 diabetics, go for it. Go for the gold. Okay. If you're older, if you're middle age, and certainly if you're middle age, probably 7 is a good goal, because you probably have had diabetes for 10 to 20 years, and it ain't going to affect whether you're going to get these bad things with your blood vessels. But we're going to get to drugs that may have an effect, all right? But that tight sugar is not going to do it. The new drugs may do it. The tight sugar, no. And by all means, if you're older, if you've already had low blood sugar episode, if you're in your 80s and 90s and maybe even 70s, but certainly 80s and 90s, if you've already had heart attacks or strokes, if you've been in the hospital, forget trying to get your sugar tight. 8 is fine. Anything less than 8 would be fine. Okay? So we're not going crazy with this A1C glucocentric approach anymore. The new approach by the American Diabetes Association is what I'm telling you. And the American Diabetes Association, they're still pushing their number one, they're still pushing what we talk about, which is what, James? Diet and exercise.
Yeah.
Diet and exercise. And there's no question that you can cure pre-diabetes and even diabetes with diet and exercise. It can cure it. Okay.
And that's for type 2, correct?
Absolutely.
Yeah.
Type 2, type 1 is lifelong insulin. Type 2 is a different problem. Your body's not reacting to insulin; it gets resistant to it. I compare this to the EGFR thing. I mean, don't get obsessed with EGFRs going from 40 to 50 and 60 to 40 and whatever, and don't be obsessed with your A1C moves a couple points. Try to keep it in a reasonable range, like we just discussed.
Now I have a question, Doc.
Yeah.
What is the difference between blood glucose on my labs and A1C?
The A1C is what they call glycosylated, glycated hemoglobin. In other words, hemoglobin gets some kind of glucose attached to it. And when we look at the hemoglobin, which is part of your blood, with the glucose attached to it, it gives us an idea about how much sugar has been in your body in the last 90 days. So it's giving us a rough index of how your sugar levels have been in the last 90 days. That's the A1C, or glycated hemoglobin.
Mm-hmm.
As opposed to sugars are moment to moment. This kind of gives you a rough idea of how good it's been for the last few months.
Now, should I keep an eye on my blood glucose, since I see that often when I get my labs? Mine's usually, it's under 100. Mine's 90 or 80s or 70s.
Do not worry. Do not worry. James, I think the main thing is a lot of people out there that are listening to this show, their doctor may have jumped on them to treat diabetes. I mean, this is all part of the business of medicine. We pass antidepressants, we pass all kinds of drugs. I would say, ask your doc if you could try lifestyle, and unless you've got one of the things we're going to talk about in a minute, you've definitely got diabetes and you've got one of the atherosclerotic problems, then some of these new drugs may be for you. But most diabetics, the first approach is lifestyle and diet and metformin. As long as those of you that are CKD, if you're CKD 4, less than 30, metformin is generally not recommended. Although I have to admit I've used it in some of my patients. But these new drugs are even better than metformin. Metformin used to be the go-to drug, a really good drug. Some people get stomach trouble, diarrhea with metformin, and some of these new drugs can give you a problem. But number one thing is diet and exercise, and then metformin. So basically, we're talking about the new approach to diabetes, and we've been waiting 20 years to get something really exciting, and it's here now. So you want to, what I've talked about last time is you want to get the most bang for your buck. And a lot of people say, oh, what if I, go on a low protein diet or a very low protein diet? Zero bang for your buck. You're going to waste a lot of bucks, especially if you buy those supplements. No bang for the buck. Protein restriction is useless compared to the other things like what, James? Controlling your blood pressure.
Yeah.
We know that works. And I'm going to reiterate, I think James said you had a blood pressure talk this week. Since 2017, the new study that came out, you are 120 to 129, you're considered elevated. If you are 130 to 139, you're stage 1. Now, that stage 1 may be a lot more important than the stages 1 and 2 of CKD. And if you're over 140 or over 90, you're stage 2. And if you're diabetic, we talked about this in a previous show, your goal less than 130 over 90. And if you're a young diabetic, I may even try to go for 110 to 120. Certainly, getting that blood pressure to that 120 range will benefit your heart, your brain, your kidneys, your eyes. That works, okay? Do what works. I think I'm starting to.
We can hear you fine. The video's
You
looking a little compressed, but it's okay.
Oh, well. Anyway, okay. So we know that blood pressure control works. We know that controlling your lipids works. Getting your LDL. There's a guy named DeFranzo. He's the godfather of diabetes. I know the guy well. I've been in many meetings with him. He goes for 50 in his diabetics, an LDL of 50. That's aggressive.
Woo! Yeah.
Yeah. And if you really want to be aggressive, I mean, I think 130 is less than 130 is good for diabetics, but I might even go for 120 if you're young. What about your diet? We all know that we eat way too many calories, and most of the stuff we eat, 90% of them is in processed foods. so-called health foods, which are not healthy, the granola bars, the energy bars, the yogurt with all the sugar added, and all the, the baked goods, the noodles, the crackers, the chips, not good. You want to try to get to a low carb diet. It will benefit your kidneys and benefit you in terms of getting sugar control and hopefully avoiding some of these problems that are related to long-term high sugars. Get rid of the sugar sweetened beverages in your house and get rid of the foods with added sugar. And you know that when you eat those, pop a lot of sugar, your sugar spikes, and then it drops. And what happens, James? When it drops, you get what? More hungry.
You
then
get
you
more
wind up eating
hungry,
more.
and you could go into it like a sugar, well, what I call a sugar coma, where I'm just like, oh, I don't feel like exercising or moving. You just want to veg out, which is not good for you.
Yeah, no, it's definitely not good. And you're going to want to be eating more. So you want to try to eat and go. I'll go back to some of my talks about low carb diet. I talk about the plate method. You want to eat a lot of fiber and vegetables. The plate method, to summarize, it's an 8-inch plate. You do about a half of it. Load it up with any vegetable you like in all kinds of ways you want to prepare them. I love vegetables and salads. That's a half the plate. Another quarter of the plate is your protein. Another quart are your carbs. And the carbs you should eat are whole grains, brown rice, oats, barley, quinoa. Keep the skin on your vegetables and your potatoes. And remember, the protein and fat will help fill you up. And diabetics cannot be on a low protein diet. I'll reiterate, the kidney organizations, the American Diabetic Organization, if you got kidney disease, 0.8 grams per kilo or 0.4 grams per pound. So if you're 200 pounds, that would be around 80 grams. If you're 150 pounds, around 60 grams. So you're not talking about these extremely low protein diets. Useless, dangerous. Do not try to be on
very
these.
dangerous.
Very dangerous. All right. Okay, so we're going to get into
and when it comes to that diet, you got to be careful with those foods that appear healthy, like you mentioned earlier. A lot of those ones that say like low fat, they substitute that fat they took out with sugar. They just load it up.
Exactly. And the best thing to do is eat the real food. Eat real foods. Eat real fruits and vegetables. As much as you can afford, get yourself eating fruits and vegetables and nuts, and the olive oil and the avocados, if you can afford that, and I know it's not easy for everybody to afford. So as we said, to date, all the studies, no clear benefit to your atherosclerotic cardiovascular disease, your strokes, your heart attacks, your blood vessel problems. And so that's why these new drugs are game changers. Before you worry about the new drugs, if you've already had a stroke or a heart attack, what common thing, James, should just about anyone, if they can tolerate it, if they've had a stroke or a heart attack, what little pill that's very cheap should they take every day?
A little 81 milligram pill?
All right, James. Aspirin.
Low dose aspirin.
Nice. Stop the damn cigarettes. Number one thing to do. Stop those cigarettes. Get your statins going. Get your LDL certainly below 100. And if you're diabetic already, I would say under 60. And my buddy says under 50. ACEs and ARBs. All the studies of these new drugs, these game changer drugs, you had to be on an ACE and ARB. That's the basic treatment. We already know that the ACEs and ARBs, we call them the prils, like captopril, which are the ACEs. The ARBs are the TANs, like losartan. Those drugs are beneficial for kidney patients who are diabetic and have protein in the urine. Now, so you don't want to forget about getting gold blood pressure, and you don't want to forget about the other things that are important if you've got atherosclerotic cardiovascular disease. But now we have well-researched drugs that can benefit not only diabetics, and you're going to hear a lot more about these drugs. They're even being used in non-diabetics. How do you like that?
Hey,
And
I love it. Everything I've read and heard about them, awesome.
they will be used in non-diabetics with kidney disease and non-diabetics with heart disease. So it's not going to be just diabetics because they're really good drugs. So we have said this over and over again. The folks that are going to get the most benefit from tight blood pressure control down to 110, 120, the ACEs and the ARBs, these new drugs that I'm going to mention soon, are which type of kidney patients are going to get the most benefit and which are going to be harder to show a benefit, James.
I am not sure.
What particular part of your kidney problem predicts how much
Protein
benefit?
leakage.
You got it, James. You hit it. The more protein in your urine, the more you're going to benefit for real tight blood pressure control, ACEs and ARBs, pushing them, these new drugs that I'm going to mention. And the one time that I would consider the very low protein, if you've done everything else, if you're young, you got a lot of protein in the urine, and you are stage 4 or stage 3B, I would at least entertain very low protein. That's the only situation. Otherwise, the rest of you are doing something, you're playing with fire, you're doing something that has no real science behind it. And if you're diabetic, absolutely not. Now, the group that I'm talking about, young folks, would be non-diabetic young folks, because you can't push low protein diets on diabetics. Okay. So the new drugs are not for type 1 yet, but they may be recommended for type 1.
Type 1 could use so much help. That would be awesome in the future.
Yeah. And, I mean, just to reiterate the urine protein groups, in this country, it'd be less than 30. Outside of this country, in Europe, if you go, this is milligrams per milligram. If you go milligrams per mole, it's divided by 10. So the three groups are less than 30, 30 to 300, and over 300. Mild, moderate, severe. Make it simple. Mild, less than 30, 30 to 300, moderate, over 300, severe. This is kind of arbitrary. And divide that number by 10 if you're using millimoles. So the studies have been primarily in patients with eGFRs of 25 to 60, and they can be used. And in actually, the two types of drugs are called. Do you know what they're called yet, James? The two classes of drugs.
SGLT2s.
Yay! All right, James, you got it. Look at you. Look at you. Okay, now I don't know if I'll give you the tougher question. What does SGLT2 mean?
No, don't give me the tough question. I am so excited to have gotten that one.
Okay, S stands for sodium, G stands for glucose, sodium, glucose, T stands for transport. Okay, so what's happening in your kidney is your kidney, go into the book and you'll get the anatomy of the kidney, and in the tubules of the kidney is where sugar and sodium or salt gets reabsorbed. And these drugs get that stuff in your urine. You're peeing out sugar and you're peeing out sodium. And so when you pee out sodium, you can get a little dehydrated and thirsty. So you got to make sure that you don't allow yourself to get too dehydrated. And you pee out sugar, it gets your sugar under control and gets your A1C. But the big thing is that these drugs, as opposed to a lot of the other drugs, including insulin is a terrible drug regarding hypoglycemia. I can't tell you how many folks I know that have come close to dying or died of low sugar because they got too much insulin.
Mm.
So yeah, low sugar is deadly. These drugs won't cause that dangerous low blood sugar, and that's why they're also recommended. Um, and the other type of drug is the GLP-1. Okay, well, we won't test you on the. It's the GLP-1. There's no name. It's a receptor. Okay.
Okay,
What this?
good. I have no clue. I can
No, no, no,
guess.
no, no. Yeah,
Glucose.
it's a glucose protein 1 receptor. It's basically a receptor in the pancreas, and this drug increases insulin, which is great, and it will slow your stomach emptying. That's the GLP-1s. Help people lose weight actually, and slows glucose absorption. I'm not going to delve into these in any great length tonight, because this is going to be for another show.
Yep.
But and I want to be able to get to some questions. And so, just in general, the people that the American Diabetes Association, the heart doctors, the kidney doctors, everybody's in agreement that they should be considered for the SGLT2, the GLP-1s, are people that are older, have already got atherosclerotic disease, whether you got heart failure, if you got kidney disease. I mean, there's a lot of you. You've got abnormal kidney function. You've got protein in the urine. You've got history of heart attack, history of strokes. You've got high blood pressure, and your heart size is thick, called left ventricular hypertrophy. A lot of indications, and a lot of people that will qualify if you can afford it. Now, these drugs are expensive, and that's something we'll talk about in another show. But there's a lot of indications for these drugs. The drugs are the gliflozins. The SGLT2s are the gliflozins, a mouthful, right? And there's a canagliflozin and a dapagliflozin. James is going to give you a list.
I'll put them. I have the list. I'll put it in the description after the video.
So again, people that
but they are
had
expensive.
They are, and they're going to get cheaper. James, is like anything else. They will get cheaper. The word is not out. It'll take a few years. I mean, those of you who are on Dadvice TV, you're getting the up-to-date stuff. But most of the rest of folks that are not getting educated like this are not going to hear about this for a couple of years. So they're going to come out more and more over the next few years, and they're going to get cheaper and cheaper. And they're indicated for anybody who's had a heart attack or a stroke, you've had a bypass operation, you have an abnormal stress test. I mean, all of these things. You've got noise in your neck from the arteries to your brain. You got pain in your legs when you walk, called claudication. You got thick heart muscle. So many people that would theoretically be benefited from it. And what they can do is they decrease your risk of going into the hospital with a heart failure episode, slow down your loss of kidney function. I mean, they're just ideal. Decrease the protein loss in your urine without causing low blood sugar. And people in the future are going to probably be using combinations of these. They'll be using the GLP-1s and the SGLT2s when their A1Cs are too high. They'll be adding one of these two drugs, and they will get cheaper.
Now, Mickey just asked a good question. Will the SGLT2s be helpful for someone who's 3B but no protein in the urine?
Yeah, I mean, I would say yes. And I mean, the thing is, again, as I said earlier, the bang for the buck is going to be the highest in the proteinuric patients. As you get higher levels of urine protein, as you get lower levels of kidney function, your risk of dying from one of the atherosclerotic complications, atherosclerotic cardiovascular disease, what we've been talking about, it goes up and up and up. And so it will be easier and more likely that you're going to get a benefit. Now, those folks should be the ones to get it first with the highest risk. They're going to be expensive, and I think eventually they're going to get cheaper. And people, even without protein in the urine with 3B, I don't know about 3A. I don't personally would not use it just for 3A with no other complication. But 3B will probably be reasonable to give it. And certainly, if anyone has less than 60 EGFR with any of the history of heart attacks or strokes or heart problems or chest pain, bypass operations, for sure, that will be the drug that should be used as the first choice. And just I'm not going to give the names of the GLP-1s. James will give it to you. They have very similar effects. They're both going to help you with your kidneys, your urine protein, and decrease the risk of the complications of atherosclerosis. And the first drug of these drugs, the first SGLT2, I don't know how to pronounce this, Farxiga,
I believe that one is made by AstraZeneca.
Is it called Farxiga? It's DAPA. It's DAPA. So Farxiga is DAPA. Anyway, the FDA has now said if you've got a heart failure problem and you're not diabetic, but you've got kidney problems, you can be prescribing this drug even without diabetes. The FDA has approved, and it's going to come on more and more and more of these drugs are going to be approved even outside of diabetes because they can slow the decline of kidney function, prevent end-stage kidney disease, prevent the heart attacks and strokes, and decrease your risk of hospitalization. And there's another class of drugs that I'm not going to get into tonight, but there's more good news for you folks coming with drugs that will be combined, not just the ACEs and the ARBs, but you're going to have the SGLT2s, the GLP-1s, and then there's another group of drugs that just recently came out called finerenone, and they're going to be combined to help slow the decline of kidney function for you folks now and in the future. So you got some good news out there. Good news for diabetics and good news for all CKD patients. So I'm going to just pause for a little time to chat and questions.
Awesome. Yeah, quite a few questions here. And someone, I think it's pronounced Farxiga, it looks like.
Okay.
Yeah, which may be right. But I believe it's AstraZeneca, and they are expensive. And Dr. Gibney talked about how he has made it more affordable with people that he prescribes them for, and he encourages reaching out to the manufacturer to see if they have programs, and many of them do, to make these very, very affordable. Because when we say they're expensive, they are expensive.
Well, it's not like life or death medicines. It's not like anybody who takes these medicine is going to for sure live longer. I mean, they have had benefits, and they may benefit you. Like I said, if you're at a higher risk, you need to really push hard. Like if you got higher protein levels, you've already had, trouble with your heart, and you've got more advanced kidney disease. If you 3B, I would say try to get them.
Yep. All right, let me go some questions I marked here. Philip just asked, will long-term use of ARBs cause kidney issues?
No, absolutely not. Absolutely not. The one thing, I think we've talked about this a few times, and the same thing will happen with these new drugs that we're talking about, the SGLT2s, GLP-1s. A lot of drugs will have an initial decline of your kidney function when you start them, including aggressive control of your blood pressure. If your blood pressure has been lousy, you go to your doctor and your doctor gets it under good control, you may see a pop in your creatinine and a drop in your EGFR, temporary. Same thing goes with people sometimes when they start the ACEs, they start the ARBs, and even when they start these other new drugs. It's temporary, it's reversible, and the long-term benefit's going to be there. But you're going to have to do it with a doctor who will monitor you and know that the rule of thumb is even a 30% decline in EGFR is not a reason to stop an ACE or an ARB if you've already got a lot of protein in the urine, okay?
Great. And Abby, one of our regulars, asked Dr. Rowe, can those micro blood vessels be repaired?
Um, that's a good question. I would say no. So basically, microvascular disease is diabetic retinopathy, and you can treat diabetic retinopathy. They use lasers, they use injections. Um, so is that repairing them? I wouldn't call that repair. The micro in the kidney. What are the micro vessels in the kidney we're talking about? You know the word, the little thing in the kidney that
Are they the ones
begins
that
with
go to the
G?
nephrons?
Yeah, it begins with a G. The g glow.
Glomerular.
Yeah, glomeruli. The glomeruli
Glomerular. There we
are
go.
tiny blood vessels, like a ball of blood vessels, and you can see in my book,
That's
I
right.
show
Yeah, yeah. They're like a whole ball.
all the blood vessels, and that's where the blood goes through to filter. So those are, and they don't get repaired. They don't get repaired, to my knowledge. Good question.
All right. Mark just asked a question. He made a $10 donation. Thank you, Mark. Really appreciate it. It helps cover the cost of all the streaming and all that stuff. He asks, he's diabetic with stage 3 CKD. He has neuropathy. Let's see. His podiatrist said alpha lyopic acid and L something are good for his neuropathy. Are they safe for kidneys?
I have no information on those. You're talking about B6, B12. I don't know any good evidence, and I feel for you. And I've got a very close friend who's type 1 diabetic who's got diabetic neuropathy. We have yet to come out with good treatments. My suggestion for diabetic neuropathy, I use simple things like amitriptyline, which doesn't always work. And you need to get to someone who specializes in pain treatment. And there are things that you can do, a lot of brain stuff that you can do to help control your pain. Unfortunately, not much good stuff for diabetic neuropathy.
Olivia asks, this isn't about diabetics, but it's about kidneys. Is taking diuretics bad for your kidneys?
If you should not be on a diuretic unless you need one. If you take a diuretic and you don't need it, it could theoretically be bad for your kidneys. How is that, James? Can you tell the answer to that? If you didn't need a diuretic and you start taking one, or you take one of these natural foods that have diuretic potency, or you go to a health food store and get stuff that has diuretic potency, why could that be harmful?
I am so sorry I was not listening to you talk. I was scrolling through the comments to get one ready for next.
Because if you take diuretics, it's just like making yourself unnecessarily dehydrated. If you make yourself unnecessarily dehydrated, you worsen your kidney function. So, yes, diuretics, if you don't need them, can worsen your kidney function. Anyone who's got high blood pressure should be on, at a minimum, a low dose of a diuretic to help your blood pressure control. And that would be, my usual go-to is 12.5 milligrams of hydrochlorothiazide, which is in many of the ACEs and ARBs, they combine them with HCTZ.
Now, Sandra asked a question going back to the 81 milligrams of aspirin, the low dose aspirin. Do you suggest that a person take the aspirin even though they've had a heart attack or stroke and they do not have kidney disease?
Oh, yeah. This has nothing to do with your kidneys. We're talking about prevention of another heart attack, prevention of another stroke. That's why you're taking it. It's post exposure, so it's secondary prophylaxis, meaning you've had a heart attack, you've had a stroke, or you've got TIAs, you've got transient changes in your ability to speak or move, called transient ischemic attack, brain attack. These baby aspirins can help you from getting into a real stroke or help you from getting a heart attack. Nothing to do with your kidneys. No benefit to the kidneys. High dose aspirin or high dose NSAIDs can hurt your kidneys.
Exactly. Not good.
Your kidneys. This is for your heart and your brain.
All right. John asked, does metropro, I hate saying these names, increase blood sugars? He's read that it does.
Okay. So actually, it would be the opposite to my thinking. So when you have the usual fight or flight You got catecholamines, epinephrine, norepinephrine. You may have heard that. It raises your blood sugar, gets you ready to fight, pumps up your sugar. Those are your catecholamines. The metoprolol blocks that stuff. So if anything, it could block the high sugar. It doesn't cause you to have high sugar.
Very
And as a
good.
matter of fact, it's theoretically possible that that you may not react to hypoglycemia if you're on heavy doses of beta blockers. So that you can't pump up your sugar as much. So it's just the opposite.
Aha. Now, Kathy asks, this is a transplant related question. Is there a certain A1C you should have if you've had a kidney transplant?
Well, this is interesting. So here's that's a great question. Here's off the top of my head. I think it's a great question. What I would do is thinking about what we just talked about tonight, that if you get your blood sugars up even before you're diagnosed with diabetes, you may be damaging your blood vessels. And why take a chance? I say, by all means, try to keep your blood sugars under control for less of a possibility of damaging your kidney blood vessels, your kidney transplant blood vessels. And especially if you're diabetic, for sure. If you're diabetic, then it's definitely, you don't want to knock off your kidney with diabetic kidney disease and you transplant a kidney. So then tight blood pressure control, tight blood sugar control would be the great idea if you can do it. Because we know if you start early and you haven't had, damage to the kidney and you control your sugar well, probably going to have a benefit. So that would be my approach.
Awesome. All right. So those are all the ones I marked. Do you see any on your end? And you might have to click to open them up. I don't know if you had them opened up on your side or not to see them. Okay. And while you're looking, hey, I see we got the Warriors Quest show. Hey there. We had Lisa Baxter on here earlier, who does a lot of videos helping people with polycystic kidney disease and who need help working through the system. And
okay, how can
there's quite a few questions tonight.
Budesonide, I think, is a diuretic. I don't know. I have Nefecon. Budesonide is Bumex, I think, and that's just a diuretic. And basically, diuretics are good for folks that have congestive heart failure to try to get the fluid out. And there certainly should be, anybody who's got high blood pressure should be on a diuretic with their blood pressure treatment. Now, someone asked about CT imaging, dangerous.
Oh, yes.
Okay. So here's the thing about CT. And the contrast that they may give you in an X-ray, whether it's a CT or some other X-ray, the radio contrast can be dangerous for the kidneys. So generally speaking, if you've got an abnormal EGFR, they're not going to do a CT with contrast. It gets even tougher because even the MR, there's something, the MR and the MRI, if they want to take pictures with an MR, there's an agent in there that also can be dangerous for patients with kidney disease. So I have an operation with stop blood pressure pills for a week before the operation. Okay, so no, if you look, everything we talk about regarding benefits or harms to your kidneys are long-term, not days or weeks. There's someone who's going to be in an operation and they're going to be off blood pressure meds for a length of time. Not dangerous for your kidneys at all. But you want to monitor your blood pressure. And if your blood pressure gets really out of whack, you may need to talk to your physician about that. But generally, the effects of blood pressure or medicines are long-term. Or diet, there's no such thing as, I just changed my diet, my kidney function got better. BS. No. All of these things are long-term processes. Just like atherosclerosis is long-term, years and decades. Nothing happens quickly with these things. Now, someone asking about sodium chloride IVs. Oh, that's nonsense. Whenever I get them, boost the EGFR. Nonsense. Nonsense. Stay away from that. Sodium chloride could be dangerous. I don't know who's giving any people sodium chloride. I don't know why anyone would do that. Sodium chloride is not a physiological solution, especially if it's normal saline. I mean, it's not a good idea. And again, you don't want to be pushing a lot of fluids to affect your lab value. You don't want to be taking saline. It means nothing.
They're just diluting it, right? Artificially.
You need to focus on long term. If low protein affects your kidneys, it's going to be over decades, not days or weeks. If going on vegetables, a vegetarian diet will affect them, it'll be, again, over decades, years at least. No quick fix. Same thing goes for your hardening of the arteries. So these are long-term things, and I can't emphasize that as enough.
Yeah, and I got one that just came up. Mark asked, and thank you, Mark, for posting this. He has no kidney stones, but he's stage 3 CKD, and his doctor told him to stay away from teas, even decaf teas. Do you know why that would be? He's not a fan of drinking just water.
Yeah, no, I think it's the kidney stones oxalate. Yeah, and the oxalate story is complicated. I'm not an expert on stones. You need to talk to your urologist and look it up. But the latest thing that I have read about is that trying to restrict your oxalate is not really beneficial. Most stones are calcium oxalate, so that's what he's talking about. Somebody put a thing in here about high plant-based diet. Do not push animal protein. So, yeah, I'm good with your dietitian. Restream reply, Philip, whatever.
Well, that's me. That's me. I was replying to Philip.
Oh,
yeah.
Oh, okay.
Philip had asked so I answered some of them in there.
Okay,
he had asked, do you recommend no animal protein at all? And that was my response, letting him know all the dietitians I work are very heavy in plant-based, but none of them say completely eliminate animal protein. It's okay to have, chicken and eggs and things like that.
Yeah, you want to take the fat off the chicken. You want to have lean meats. You want to have occasional red meat, and you want to try to use as much soy. You can make so many good foods that taste just like animal protein with soy-based protein. Somebody hand IgA nephropathy, a lot of protein in the urine, and on losartan. I mean, that's fine. Long-term losartan is fine. I mean, the main thing you want to do with anyone that's got kidney disease and protein in the urine is you want to see if you're decreasing the protein in the urine. That's a good sign. And what I would do is I would add the ACEs and the ARBs and now these new drugs, the SGLT2 drugs and other drugs, especially if someone with a lot of protein in the urine, over time, see if I am decreasing that urine protein, which is a good sign, which may indicate that we're going to slow your kidney decline.
All right, one last question, because we're at the very top of the hour, and this is Yvette's question. She's been so kind. She posted it several times, which made it easy for me to find it. Is Lasix, Lasix, bad for kidneys?
No, again, it's a diuretic. Diuretics have a purpose. You should not be on a diuretic unless you have excess body fluids, excess salt and water, which can occur with advanced kidney disease. It can occur with advanced heart disease. And if you got advanced kidney disease, like stage 4 or 5, sometimes I would use the diuretic Lasix in addition to blood pressure medicines to control blood pressure. Lasix is not a harmful drug for your kidneys.
Awesome. All right, Doc. Thank you so much for being here today. An amazing chat again. Awesome. And you'll be back next month. We have 2 shows scheduled for next month.
Yeah.
Yep. And I want to thank everyone being here. Now, if you have more questions, go ahead, put them in the comments. I go through and I'm trying I'm trying to keep up with the comments that people post. And if there's questions for Dr. Rowe, it may give him ideas of things to talk about in future shows. So it's always great to keep posting those things down there in the bottom. And this is my last show for the week. 2 shows this week. I will be back next week. I've got Lana Leip and I've got Dr. Gibney back next week. So more stuff coming right up. Thank you all for watching tonight, and I'll see you all in the next video. Bye, everyone.